All right, everybody, we wrapped up another Friday here at RP. I want to talk through the procedure that we had today, which is a little bit of an interesting case just in how I kind of look at these types of patients. So today we did a PRP procedure for the low back on the left side, the right hip. Sorry, not the right hip, the right knee, and then also the right ankle. Now, first let's talk about the low back. So this is our third injection on this patient for her low back pain. Each injection has got her closer towards being pain-free, which is obviously what we are looking for. And each time we have kind of refined what we're doing a little bit in order to further tweak. And so the very first time we treated her low back, we actually just treated her sacroiliac joint and the supporting ligaments around that because it appeared that most of her pain was coming from that. That resolved quite a bit of her pain, but then her pain kind of changed a little bit. And so a new layer came out. So then on our second procedure, we ended up actually treating the iliolumbar ligament, which is a common ligament that can cause pain in the lower back. Basically attaches the ilium, so your kind of hip pelvis bone, to the actual spine, so hence the iliolumbar ligament. We also treated the facet joints, L2-3 through L5-S1 on both sides at that time. And then we also did some subcutaneous perineural injections just to treat the overlying subcutaneous nerves. Again, this was probably about four months ago, and she did well with that, and she saw pretty significant improvements. And it was probably in the last 2 or 3 weeks she has started to notice a slight plateau in that, and so she wanted to retreat again. And so this time, based on our physical exam, we decided just to treat the left facet joints because her right facet joints clinically are not causing her any issues. She doesn't have any right-sided low back pain anymore, no issues with turning and looking over the right side, no extension, rotation would cause pain on the right side, it was all on the left side. So we treated L2-3 through L5-S1 facets on that left side. And really focusing on getting good intra-articular as well as the capsule round, which is really, really important to treat both of those structures. So we did that. We also, again, treated the iliolumbar ligament at both of its attachments on L4 and L5, and then also where that attaches onto the anterior brim of the ilium. And then we did two things that we haven't done in here yet, although we did more superficial nerve stuff before. We ended up doing some deeper nerve stuff. So we did a lumbar erector spinae plane hydrodissection. So again, I know I've talked about this before, but we find the transverse process and we have the erector spinae group that is on top of it. Take our little model here, okay? So we find our transverse process here, and then we are going to take our needle and basically advance our needle onto the transverse process. This needle is then going to lie underneath the actual erector spinae group. And when we inject the fluid there, that fluid is going to travel up and down that the fascial layer of the erector spinae group, and it's going to bathe the dorsal root ganglia. It's going to bathe the smaller cutaneous nerves that are originating down from the actual spinal canal, and that's going to give a really great pain relief for the medial and lateral cutaneous branches of the dorsal rami. Now, if you are up to snuff on your anatomy, you'll know that the lateral cutaneous branch of the dorsal rami in the lumbar region is actually the superior cluneal nerves. So because she is having pain from that area as well, we also did a nerve hydrodissection for two of her branches that were inflamed of the superior cluneal nerve. So under ultrasound guidance, we find the nerve, we palpate, we make sure that's her spot of pain, and then we advance the needle up to that nerve, inject fluid around that nerve to help manually decompress it, also to provide some nutrition to it, right? We're helping to bring new blood flow to that area. We actually have some growth factors. We have some dextrose in our solution, and so we're trying to promote the healing of this nerve. And so that was our approach today for the low back. And then we moved on to the knee and the ankle. Now, chronically, this patient's right hip has always been a problem. And when she goes and sees her chiropractor, her myopractor, her massage therapist, whoever she sees, she always has different kinetic chain aspects on this right side where that right arch is going to drop a lot more than her left side. Her right knee is then going to have more valgus stress, and so it's going to be a little knock-kneed on that right side, and all of that is contributing to a lot of tension that she ends up getting in her actual hip, right? And so we've treated the hip twice. We didn't need to treat it this time, but we've treated the hip twice in the past with PRP. She was doing absolutely phenomenal with that. But now she's kind of getting this right foot pain that's actually at the base of the navicular, which is that kind of on the inside arch of your foot is one of the bones there, which a lot of people can be tender with it. But because I think we have improved the integrity in the hip, she's now starting to feel that load a little bit more in the other areas of that kinetic chain. So if you buy into the Thomas Myers myofascial meridians ideas, which I 100,000% do, we assume, we think that there is force transmission lines through the body that are coming from one area and going to the other area, which allows our bodies to actually move more efficiently through space. What happens sometimes, though, is that because those myofascial force transmission lines, we can have weakness in particular areas, and then one specific spot is going to take the brunt of that weakness. And so for her, it was actually her hip. So along the myofascial meridian that we were treating, her hip ended up taking the brunt of it. Now we got the hip better, and so what started to show up was actually a little bit of instability in the knee, as well as some pain on the navicular, on the top side, and then also on the arch side. So after our exam, that takes into consideration these myofascial meridians, these myofascial force lines. What we ended up finding was that obviously she had some pain along the actual navicular. She had weakness of tib anterior, which that weakness ended up translating to some instability in the proximal tibiofibular joint, which there's a very close connection with those structures there. And then also some issues with her IT band, and then the LCL ligament, which all of those can be part of these myofascial meridians and the force transmission lines. And so in order to give a comprehensive treatment for her today, we treated that navicular. We also then treated the patellar tendon. We treated the LCL. We treated Gertie's tubercle, which is where the iliotibial band attaches. And then also the proximal tibiofibular ligament, which again holds so here's your fibula, here's your tibia, this is your shin bone, this is the little shin bone on the outside. That tibiofibular ligament helps to keep these things approximated well. And so that was our approach, and it's something that we frequently do here at Regenerative Performance, which is take a step back and actually look at what are some of the things that are contributing to this patient having pain in this area. So that way, in conjunction with physical therapy, in conjunction with body work, in conjunction with the mobility exercises that we've prescribed her, in conjunction with everything else she is doing for her health with her other physicians, both here and elsewhere, how can we help this patient to truly heal and not just temporarily make the pain better, even with the PRP injection, for it to just come back in 2 years because the underlying issues were not fully addressed. So that was our day. That was Friday. I hope you guys enjoyed this week. Like, subscribe, do all the good things, and I'll see you later.